everyone.
Good afternoon, everyone. Thank you for joining us today and welcome to the BOSS MSCRS Cataract Video Festival 2021. I'm Sudashini Chandrasekharan. I will be moderating this event along with Dr. Lee Man Wai today. Today's Cataract Festival is the first merger event between BOSS and MSCRS, and it's being broadcasted over two platforms, which are the MSO website and the Borneo Ophthalmology YouTube. In order to join from the MSO website, you just sign in as a MSO member, and there'll be an icon at the top right corner, which you can click to join the live event. And for the YouTube, it is Borneo Ophthalmology. Attendance certificates will be given to viewers logging in through the MSO website, but unfortunately, please note that the same cannot be done for the YouTube channel, as we will not be able to keep track of viewers over YouTube. Now, let me now introduce Dr. Dennis Kong and Dr. Lee Man Wai, who are our co-chairmen of MSCRS, and invite them to give the opening remarks. Dr. Dennis Kong completed his undergraduate studies in Melbourne, Australia, and eye specialist training in London, UK. He is the founder of the Borneo Ophthalmic Surgical Symposium, which is BOSS, which aims to promote CPD activities, in particular surgical video recordings and presentations to improve microsurgical skills in ophthalmologists in the region. He is also the founding medical director of Eye Specialist Center Kuching, which is a group of eye specialist practice and one of the largest in Sarawak and Sabah. Dr. Lee Man Wai is a graduate of University of Manchester and started his basic ophthalmic training in UK and completed his advanced training in Singapore. He also completed a vitreoretinal fellowship at Lions Eye Institute, Western Australia. He is currently the medical director at LEC Eye Center in Ipoh. With that, I'll hand over this virtual platform to Dr. Kong and Dr. Lee for the opening remarks.
Welcome to BOSS MSCRS Cataract Video Festival. Last year, we had our inaugural event, and this year is a joint collaboration between BOSS and MSCRS. BOSS has been rebranded as Borneo Ophthalmic Surgeon Section, which actually reflects us more accurately, and we now are a special interest group in MSO. I urge all ophthalmologists and trainees who are from the Borneo states to join BOSS. Also, ophthalmologists and trainees who had previously served in the Borneo states are welcome to join BOSS as well. BOSS was set up primarily to promote CPD activities in the Borneo states, as we are not only more isolated geographically, but in terms of CPD activities as well. And in particular, to improve microsurgical skills through video recording, editing, and presentations. Despite the ongoing raging pandemic and reduced workload, we have still managed to attract a record 18 video submissions this year. Congratulations to Sarawak General Hospital Kuching for a record 4 submissions, and Hospital Sultana Amina Johor Bahru for 2 submissions. The rest were just single submissions from various centers and hospitals throughout the country. Without further ado, I'll hand over the stage to my co-chairman, Dr. Lee Man Wai. Man Wai, please.
Thank you very much, Dennis, and thanks, Sudha, for the kind introduction. I think we've all been familiar with Zoom meetings and webinars for the past, well, almost 2 years now. I think, as Dennis mentioned, very innovatively, I think he did his first virtual meeting last year, and we all enjoyed it very much. I was a very privileged part of it, and he also did one earlier this year. So it's with great pleasure that we have come together with our 2 groups in the MSCRS, which actually was a special interest in cataract and refractive special interest group within MSO, and we formed the MSCRS, really the Society of Cataract and Refractive Surgery, just last year. And similar in our thinking in terms of video education, as you have attended previous physical meetings at MSO, Cataract Refractive Special Interest Group organized in hotels in KL. Now we've also done a workshop earlier this year, and all really based on video-based symposiums. So again, this is why we have come together to organize such a video festival and focused on cataract surgery, which is really our bread and butter. I think surgical instruction through video is really, really important, and hopefully this will continue moving forward and will stimulate interest amongst the young ophthalmologists. Hence, we have quite a big submission list from the young people as well, and this will be doing good things for ophthalmology in Malaysia. Now, without further ado, I think we will get on with the show. We're going to start off with an introductory video, which we're going to kickstart the festival. So over to the technical people to play the video. Thank you very much.
One.
Hope everyone enjoyed the introductory video. So now let me introduce our esteemed panel of judges, which consists of 4 experts in the field. Dr. Lee Man Wai is the chief judge of today. The other 3 judges are Dr. Chin Pik Kee, who is a consultant ophthalmologist in Sunway Medical Center, Petaling Jaya. Dr. Mahathir Al-Hadi Sulaiman, who is a consultant ophthalmologist in KPJ Kuching Specialist Hospital, and Dr. Khoo Sai Peng, who is currently a consultant ophthalmologist in Synergy Specialist Eye Center in Kota Kinabalu, Sabah. Dr. Lee?
Thank you, Sudha. So really, I think we have competitive categories this time split up into young ophthalmologists and an open category. So essentially, it's a competitive video submission, and really there's a criteria that, you know, the judges, my esteemed panel, as together with ourselves, have gone through to try and come up with the winners. So we have got, well, everybody's a winner for submitting, but we do have 6 winners today that's going to be present to actually answer questions about your videos. And the second and first runner-up in each category are going to be going home with an external hard drive, a 2 terabyte hard drive, so that they can actually record more videos. And the winners in each will get 4 terabyte. So I think these will be useful, practical prizes rather than any big trophies or anything. I hope, you know, this will be inspiring for people to continue to make more videos and submit. So let's move over to the first category now. We have the young ophthalmology category, and I think Dr. Chin Pik Kee will be presiding over this. So over to you, Pik Kee. Thank you.
Thank you, Man Wai. First of all, I'd like to thank the organizers for the privilege of joining the esteemed panel of judges for this festival. In the YO category, we received 8 entries, which were very credible productions for first efforts. Well done, everyone. Now, before we start announcing the results, I just want to point out that videos are judged based on fixed criteria. These cover video quality, audio quality, and educational value. So if there's a tip that I can give to the presenters, it is to pay close attention to the competition rules. For instance, if the submission guidelines say that narration is vital, you have to have a narrated video to be in the running for a prize. And to any trainees in the audience, this is also a reminder that a video competition is not a contest of scientific merits alone. So you should evaluate for yourselves the content to see what you can adopt into your practice or otherwise. And now to get on to what we are all waiting for. In the young ophthalmologist category, the second runner-up is the video entitled Single Point Scleral Fixation of a 3-piece IOL for a case of traumatic cataract with significant zonular dehiscence. This entry was submitted by Dr. Lim Hui Wen from the Hospital Sultana Aminah Johor Bahru. I personally like this kind of descriptive, albeit long titles, because it really helps the viewer to zoom in on which videos they want to watch first. To my mind, we all strive to do our best for our patients within the constraints of our skills and what is available to us. In this video, the surgeon makes commendable efforts to restore a traumatized eye. However, for another case like this, in other circumstances, a surgeon might well choose another IOL fixation method instead of using Prolene 10O, which degrades with time. Anyhow, congratulations, Dr. Lim, and let's have the video, please.
This is a case of subluxated crystalline lens with more than 180 degrees of zonular weakness following a blunt trauma. For this patient, we have proceeded with pars plana vitrectomy just to clear his vitreous hemorrhage. As for his subluxated lens, what options do we have here? We can either perform aphecal emulsification, putting the lens into the bag with the support of capsular support devices, or proceed with lensectomy followed by sclera IOL. Iris claw extensive iris damage. In this case, we are going to demonstrate phaco emulsification in a subluxated lens followed by lens fixation in capsular bag using single point sclera fixation technique. Continuous curvilinear capsulorhexis is performed. This is a challenging step due to mobile lens. Hydrodelineation is performed. This is followed by direct phacoemulsification. Do take note that this step is performed with extra caution due to underlying zonular weakness. As we can see here, red reflex is not observed due to underlying traumatic vitreous hemorrhage. Viscoelastic is then injected into the capsular bag. Pars plana vitrectomy is then performed to remove the vitreous hemorrhage. As we can see here, the red reflex is now present again, which helps with the visualization of capsule and lens. The capsular bag is expanded with generous amount of viscoelastic. A 3-piece intraocular lens is delivered into the capsular bag. The externalized lens haptic is repositioned into the capsular bag. The lens haptic is now at 4 o'clock position. In this case, the intraocular lens will not be well supported due to underlying zonular weakness and overlying iris trauma. A conjunctiva peritomy is created from 2 to 5 o'clock followed by a partial thickness sclera flap. A 10O polypropylene suture on a straight needle is introduced under the haptic via the partial thickness sclera flap. The needle with the accompanying 10O polypropylene suture is then passed under the iris and haptic and over the optic, exiting through the opposite cornea incision site as guided by the bore of a long and hollow 25 gauge needle. The needle with the suture is now inserted through the cornea incision, which then exits through the opposite partial thickness sclera flap. This time round, the needle will be placed above the haptic, thereby forming a loop around the haptic. Generous amount of viscoelastic is used to expand the capsular bag. This will help to reduce the risk of posterior capsule rupture along the track of the needle. The two ends of the suture are then drawn up and tied in position, recentering the intraocular lens. At this point, the haptics should both be under the peripheral iris and the optic should be in a central position. IOL tilting and decentration of IOL must be avoided. Last but not least, the iris trauma is repaired to restore as much iris contour as possible. Finally, the sclerotomy and scleral flaps are sutured closed, and the scleral flap should be overlying the buried suture knots, reducing the risk of exposure. In summary, we describe a novel, straightforward technique that employs single-point fixation of an IOL in an eye with extensive zonular dehiscence. However, this technique is potentially limited by the risk of long-term suture breakage and development of UGH syndrome. Therefore, greater emphasis should be placed on IOL positioning and suturing technique in order to achieve the best possible surgical outcomes. Practice makes perfect. Good luck.
1.
Well, that was quite a beaten up eye, wasn't it? Well done to the surgeon indeed. All right, now moving on. Next, the first runner-up in the YO section is the fencing dual, modified 4-flanged sclerofixation technique produced by Dr. Tiong Kiew Eng, who is from the Sarawak General Hospital. The strong point of this presentation is a coherent and well-researched script, although it does use quite a bit of borrowed material. This video demonstrates a useful technique that can be added to a surgeon's armamentarium for fixing an IOL in the absence of zonular support. Congratulations, Dr. Tiong. The video, please.
In the journey of young ophthalmologists, becoming a trustworthy and confident cataract surgeon is always what we wish to be. When we encounter the patient with aphakia, what are the choices of intraocular lens that we can offer to our patients? Whether it is anterior chamber intraocular lens, retropupillary iris fixated intraocular lens, or sclera fixated intraocular lens. Complications of anterior chamber lens are well studied throughout the times. One of the most common complications is endothelial cell loss. Retropupillary iris fixated intraocular lens is a good alternative of choice as it can be performed without much difficulty. On the other hand, sclera fixated intraocular lens is more challenging, especially for the young ophthalmologists. Various complications that arise from the sclera fixated intraocular lens can be a discouraging factor for the young ophthalmologist who wishes to proceed. In 1991, Dr. Lewis proposed the sclera fixation technique with the sclera flaps and ab-asteral suture. In 2007, Dr. Sharoff first described the sutureless intrascleral fixation of the intraocular lens. In 2008, Dr. Akawa introduced the usage of fibrin glue application to the sclera flap for sclera fixated intraocular lens. In 2017, Dr. Yamane published a sutureless transconjunctival intrascleral fixation technique with the elegant double needle technique. In 2019, Dr. Ciego Canabrava proposed a sutureless sclera fixation technique named the 4-flange technique with no flap, no knots, and no glue. These are the simplified steps for the 4-flange technique. Step 1. Insert the needle from the sclera into the eye, then thread the suture into the needle. Step 2. Repeat the same procedure at the opposite side. Step 3. Insert the suture into the eyelet of the haptic, then make the first flange. Step 4. Insert another suture into the other eyelet of the haptic, then make the second flange. Step 5. Insert the intraocular lens into the eye and center it with the prolate. Step 6. Cut the suture and make the third flange. Step 7. Cut the other end of the suture and make the fourth flange. In this video, I'm demonstrating some simple modification to ease the process of 4-flange sclera fixation technique. In the original 4-flange sclera fixation technique, the sclerotomy measured 2 mm from the limbus is performed. Then the Prolene suture is inserted into the 26-gauge needle with the help of the microforceps. In my case, I am demonstrating preloaded Prolene 5/0 suture into the 27-gauge needle. The same procedure is repeated on the other side. Anterior vitrectomy is then performed to remove any residual vitreous in the anterior chamber. Subsequently, ophthalmic viscosurgical device (OVD) is injected into the anterior chamber. The 27-gauge needle with preloaded Prolene 5/0 suture is checked properly to ensure suture in place. A sclerotomy measured 2 mm from the limbus is made at one side using this 27-gauge needle. The preloaded suture is then advanced slowly until the suture is visible. The microforceps is then used to grasp the suture and exteriorize it. As you can notice, the eyeball is soft during the first sclerotomy. OVD is further injected into the anterior chamber to keep the eye firm. Second sclerotomy is performed in the opposite side with similar method with much more ease after filling in adequate OVD. Here comes a beautiful fencing duel in the eye. Suture is then passed through haptic eyelid and first flange is created using portable cautery. Insert the other suture's end into the other eyelid and make a second flange. Both flanges are tested individually for their steadiness and stability. It is an important step to ensure the flanges do not slip through the eyelid of the lens. The intraocular lens is then inserted into the anterior chamber with the help of the forceps. Intraocular lens is then centered via the adjustment of the Prolene sutures at both sides. Once the intraocular lens is in place, remove the excessive Prolene suture at the base and make the third flange. Similar procedure is repeated on the other side and make the fourth flange. The flanges are then buried under the conjunctiva. Is this a safe technique? Recent study published in this year in Journal of Cataract and Refractive Surgery shows that this is a safe technique with short learning curve, satisfactory vision outcome, and stable intraocular lens position. However, more data are needed. What are the learning points from this case? I have found that this technique is easier to master, especially for the young ophthalmologists. With this modification, preloaded suture performed outside the eye can be more convenient and easier for the young ophthalmologist to handle, as the original maneuver is performed inside the eye. This technique is useful, especially in certain cases when the corneal view is poor. The extra point I have learned from this case to make sure the eyeball is firm enough, either with the help of the OVD or NC maintainer, so that the sclerotomy can be performed easily. Modified 4-flange sclera fixation technique is no doubt an excellent technique which provides a great alternative for sclera fixation, especially for the young ophthalmologists. My special thanks to all the great ophthalmologists out there for their sharing, creativity, and encouragement, giving me the guidance and light which made the journey of young ophthalmologists easier and colorful. Thank you for watching.
1
Well done, Dr. Tiong. And finally, the winner of the YO category of the BOSS MSCRS 2021 Video Festival is a case of congenital cataract surgery using a corneal approach 25-gauge vitrectomy system by Dr. Chua Lozen, also of the Sarawak General Hospital. This video shows a skillful and elegantly executed surgery in a challenging infant eye. The commentary is very clear and every step is described very well. It is not easy to do a manual capsulorhexis, anterior or posterior, in the pediatric eye, and this is a technique that can be used instead. Congratulations, Dr. Chua, and congratulations to the Sarawak General Hospital. And now, let's watch the winning video.
This is a case of bilateral congenital cataract secondary to tortuous infection in a 1-year-old boy. 2 cornea side ports are made at 2 and 10 o'clock with 25-gauge NVR blade. Triphon blue dye is injected into the AC for approximately 20 seconds to stain the anterior capsule. Viscoelastic is injected to form the AC. We use Discovis in this case. A 25-gauge vitrectomy probe and an infusion cannula are introduced through the side ports. Anterior capsular opening is achieved with a vitrectorexis with a low cutting rate of 2000 cuts per minute, IOP of 25 to 30 mm mercury, and the aspiration flow rate set at maximum 600 mL per minute with a linear pedal control. Cutting edge of the vitrectomy probe is face down in contact with the anterior capsule to make an initial central capsular opening and then further enlarge towards the peripheral until the preferred shape and size of 5.5 mm are achieved. As it is known that anterior capsulotomy in younger children is very challenging because they have a very elastic capsule and not easy to control. One of the advantages of vitrectorexis over a manual CCC with a cystotome needle or Utrata is the chance of extensions or radial tear of anterior capsule towards the peripheral is extremely low. Lens metal is aspirated using the same probe with the cutter off setting. We engage the bimanual approach in this surgery whereby the cutter and infusion cannula sites are exchangeable where needed. The vitrectomy cutter was turned on while aspirating the denser nucleus and turned off again while aspirating the soft lens metal and cortex. With a 25-gauge vitrectomy system, AC stability is well maintained. A 25-gauge MVR blade produces a cornea incisions of 0.5 mm, which matches with the size of vitrectomy probe and infusion cannula, so there is no wound leak during the surgery. This can reduce the risk of repeated iris prolapse, PC-RAN, and a post-operative intraocular inflammations. Moreover, the IOP maintained at a more physiological state and the aspiration rate can be controlled with a linear foot pedal. After removal of all the lens metal, capsule is polished using the same vitrectomy probe. Thorough cleaning in pediatric cataract is crucial to reduce inflammations and capsular fibrosis. After the cataract aspirations, posterior capsulotomy is done with the same vitrectomy probe. The size of the posterior capsulotomy opening was a little bit smaller than the anterior capsulorhexis. Anterior vitrectomy is performed with a maximum cut rate of 7,500 cuts per minute to reduce the risk of vitreous tractions. We use intracameral triamcinolone to ensure there is no vitreous in the capsular bag and aim to reduce post-operative inflammations as this is a case of tortuous-related congenital cataract. As demonstrated, anterior and posterior vitrectoraxis are more precise, controlled, and quick with vitrectomy cutter. And now, viscoelastic is injected to inflate the capsular bag. Side port at 10 o'clock is enlarged to 3 mm using a 2.75 blade for IOL insertion. Single-piece SA Acrisoft IOL was implanted with the target refractions of +3 diopters. Viscoelastic is removed with the same vitrectomy probe. Both cornea incisions were closed with a 10-0 vicryl. 3 sutures is put on the wound at the IOL insertion site and 2 sutures on the side port. So we put on a total of 5 sutures. Subconjunctival injections of cefuroxime and dexamethasone are given at the end of the surgery. On post-op day 1, the child was able to freely open his eyes. Very minimal conjunctival congestions at the incision site, which resolved at 1 week post-operatively, and the pupil is round with no opacifications at the visual axis during the follow-up period. As you have may notice, only 2 instruments are required to perform majority of the surgical steps, which are anterior capsulotomy, lens metal aspiration, polishing of the lens capsule, posterior capsulotomy, anterior vitrectomy, and the OVD removal. In summary, pediatric lens aspiration via corneal approach 25 gauge vitrectomy system is an alternative to traditional surgical method if the facility is readily available. It is easy to perform, safe, effective, and less time consuming in the management of congenital cataract in younger children.
Those were great videos that we saw earlier. Congratulations to the 3 winners who are Dr. Lim Hui Wen, Dr. Tiong Kiew Ing, and Dr. Chua Lozan. So I can't wait to watch the rest of the videos on the YouTube later. So now we're going to have the Q&A session. If you have any burning questions, please do post them in the comment section, either on the MSO website or the YouTube. Dr. Lee will be conducting the Q&A session now. So winners, I hope you're prepared to answer all the burning questions.
Okay, thank you, Sudha. Well, I think everyone's enjoyed those 3 videos. I think obviously questions, might come now. I think if you have, like Sudha mentioned, post either in the comment section in YouTube or in the MSO website. If you're viewing, there is opportunity to type in your questions there as well. I think for those panel members here as well, if you have questions, you can type up in the Zoom chat. I think we can answer that as well. So I echo the congratulations from Dr. Sudha and from all our judges as well to the winners. I think Sarawak SGH has done very well. I think we've got top 2 of the 3 here from SGH, and very interesting videos. And we'll go, I think, step by step. I think I'll actually start off with, the presiding judge, Dr. Chin. I think she obviously gave her comments about the different videos. Have you got any questions? For perhaps we start off with the second runner with scleral fixation in that complicated traumatic eye. Do you have any specific questions for the surgeon or the producer?
Yeah, I was wondering how you made the decision to use a single point fixation and using Prolene 10-0. Knowing, you did say that, it might degrade with time. Was that what was available to you?
Yeah, the Prolene 10-0 is only available suture in hospital. Ideally, you can try Prolene 9-0, or even you can try on these are Cortex suture. But unfortunately, we only have a Prolene 10-0 suture.
Yeah, Gore-Tex is certainly not available in Malaysia. Yeah.
No, not Gore-Tex.
Yeah.
Have you tried have you thought about using the wider ball, 6050 Prolenes to actually do that kind of repairs as well?
Yeah, I think we don't have that Prolene. We don't have the Prolene suture of 5060.
Oh, right.
I think it's work if you try. Actually, this surgery is some sort of rescue surgery. I didn't plan to do on a single point scalar fixation initially. So because pre-operatively I thought the lens, the PC is ruptured, it might end up with lensectomy. So because on the spot I saw the inferior joint actually is quite stable. That's why I just need to secure the superior haptic only. That's why I come up with this single point rescue technique.
Okay.
Do you have access to capsular tension rings or Sioni rings or segments?
Yeah, that one need to pre-order.
Yeah.
But because the capsular division is quite large, I just putting in the capsular tensioning, it might not work. You might need capsular tension segment or Sioni ring to suture the position back to the center.
Yeah, I think now with all these advanced techniques available and that we watch, on YouTube and at meetings and all that, we start to have to put, to get ready on standby, all sorts of things in our OTs, just in case, we encounter such cases, Yeah. But anyway, that was a very challenging surgery and yeah, you did very well. Yeah.
Okay, thank you.
Well done.
Thank you.
Can I ask a question?
Yeah,
Sorry.
I was just saying, Dennis looked like, something about to come out from his mouth already. So I was going to ask Dennis. Yeah, go ahead.
I actually missed a bit of the video because I was a bit confused. So anyway, was the CCC was intact? Was it the
CCC was intact? Yeah, I did the intact CCC.
Yeah, I think that'll be a great chance to actually put in something like CTR or a CTR with a fixation arm. I think it's really will, keep the vitreous away from the interior chamber. I think
I do agree with you.
Yeah, and I think and it's actually easier to fixate, like a fixation arm to the sclera, rather than looping. I find that anyway, rather than looping a haptic, because you may not get very good centration. That's my personal experience. I don't know about the other panel judges and.
One of the things that you find if you're looping I think it was a 3-piece haptic, right, this time?
Yeah, 3-piece.
Yeah. If you're looping on one side, I think one of the issues at this point, I think the centration is okay, is in the long term, whether you can get the tension right. Because sometimes you find that you fixate one side, the other side may be pulled on, and then over time you might have some loosening on the other side as well, especially in the traumatic eye. So a lot of the time, if you're going to fixate one side, especially if you're going to loop a haptic, you might have to loop the other side as well, so that you can get proper long-term fixation. But I suppose, in a lot of scenarios, I think we always have the benefit of hindsight as to what we can do better. Unfortunately, we will dissect videos like that because we are not in the situation. I think you can only deal with the tools that you have. A lot of the time, I think in the scenario, if you don't have CTR, you don't have things, those are things that we need to have as a backup now, as to, sometimes you have all these things sitting there waiting to be used, but you don't use, and what happens is cost involved as well. So we understand that. Any other comments from the other judges, Mahathir or Dr. Koo?
Dr. Lim and Dr. Ling, just a question. When you pierce the needle through the capsule, any high risk of extending the RAN or the capsulotomy?
Yeah, surprisingly, it doesn't cause any tear or rent of the posterior capsule. With the adequate viscoelastic, like this is also one of the things quite surprised me. But I expected if it tear, it's also, I will just tie the, because it tied on one side, but I don't expect it will tear further to the other side. So, but when I pierced through the needle, 27 gauge needle, it actually didn't tear to the PC. It's okay, I think.
Can I ask a question to Dr. Tiong on her case with the fourth flank scleral fixation?
Sure.
Interesting to see the case. In your once you have done this case, have you tried to explore to see whether there's any other lenses that you can use for this technique other than the CZ70?
If using this technique, so far that
for my limited experience. I'm using the CZ70BD for this, but it's using the other types of the technique, maybe Yamane, then I think Avanci is a good choice for that. Yeah.
No, what I mean is, you know, in order to perform the similar technique like yours, other than CZ70, have you encountered any other lenses, especially foldable lenses, with any haptics that can, you know, because your method is good, but the lens is big. So have you tried to explore to find out whether there's any 3 pieces lenses that can perform, you know, the method you show, but a foldable one that you don't have to extend the wound so big? This is 7mm, which is, you know, if you've done enough phacoemulsification, then, you know, if one day you need to extend to 7mm, you will suddenly find that the wound is really big.
There is a new developed lens, I think from Zeiss, for the recent MSCRS, that actually have this preloaded IOL, which they perform in this kind of technique as well.
Oh, you mean it's got an eyelet on the haptic?
With eyelet?
It's just yeah, it got the eyelet in the haptic and it's preloaded somewhat. I think it's just newly developed. Sure, this is the, it's why
it's preloaded.
Maybe I have eyelets.
You have to thread the eyelet inside the eye.
Haptics, it's something that we can consider.
I think a possible lens you could use is MSCRS, you know, by Bosch and Lomb. It's actually got, you know, MSCRS is actually like got two dog ears at each end, and you can loop it around quite nicely to get a good fixation. I have used it before, but it's a bit tedious. I find looping around, so I prefer. I mean, if you later on I prefer doing just a simple Yamane technique. I think it's simpler, but you could use an MSCRS lens. You know,
I think that
are you familiar? Yeah,
that was
with this technique
one.
Also. Do you imagine? I can imagine. You know, you are fixing pulling the lens from just one point with your suture. Looking at the geometric of it, there's a possibility that the lens may tilt. You know, do you think the lens may tilt if, let's say the knot is not positioned exactly? You know, the force on both sides is not exactly the same. The lens may tilt, you know, because of single point fixation.
Do you
think that can happen?
There is a possibility for that. For my video, actually, I put it from both sides together, like a Yamane TV. I put it in the same tension so that to secure it as a place that I want as much as possible. Yeah,
because I seen now when you talk about the plate haptics, then I recall the other surgeon that you mentioned. When he actually tried this on 4 points fixation, he has presented a paper where he actually really 4 points, you know, on MSCRS lens, because MSCRS has four haptics. I mean the haptics of 4 holes, so actually it's four points that he's fixing on the sclera. That definitely will be, you know, definitely will eliminate the tilt.
Yeah.
But talking about 2 points. Something about the 2 points, when you fixate the plate haptics with 2 points, even though there are 2 holes, there's a possibility that the plate haptic may tilt also.
Yeah, but they do have these studies regarding these 2 points of fixations. Then they found out from the 11 cases they have done, for the risk of IOL tilt is actually much lesser, not that significant. Yeah.
And can I just go back to the first video? Actually, I mean, talking about the suture material that we have been discussing just now, I've used a lot of 10O proline actually for a scleral fixation, and it's it lasts quite long, stable. And at one point of time, I had to remove one scleral fixated IOL, and I find that it's quite difficult to remove. It's not easy to really, you know, undo or cut the suture. So I think it's quite fine to use a 10O proline. I know it's very fine during the procedure. It looks, you know, very fragile, but I've used that quite a number of times, and you know, it lasts quite long. Yeah, I mean, looking at the suture material, I know it's very fine and look very fragile. but it's quite okay.
I don't know
Can I
whether
ask another question? Yeah, congratulations to Dr. Chua. Well, it's very innovative to see you using a vitrectomy cutter to perform the CCC. So in your opinion, do you think you can use a similar technique for adult CCC, adult cataract CCC?
Hi, thanks for the questions. To begin with, this one, I especially want to thank my talented surgeon of this video, Dr. Ho. He's actually the surgeons of he's the VR surgeon here. So I'm the only the script writer for him. Okay. Yeah, I believe, but I think Dr. Ho will have a better answer. But I believe that we can use similar method for adult cataract. It's just that whether it's cost effective or not.
The way you cut it, don't you think there is a, the continuous way, Rexis, we is strong is because it's continuous. So is it easy? I mean, I'm really not sure. You have shown the video, but is it easy to actually make the, this Rexis a continuous one with your cutter?
Shall I answer?
Yeah,
I think the surgeon has to answer really, isn't it?
Yes, it has been this technique actually has been published before, and it has shown that the CCC is quite stable. Well, CCC is quite tough. Yeah, and there were times when I tried to remove the cortical matters, and I might stretch a bit on the capsule, and then it is still quite stable. Yeah, and it can be used in adult, especially in cases where you might have white cataracts that you think that it might easily extend, because as I remember, there was one case, there was one video where in APCRS long time ago, when they said there's a punctural rexis using the phaco probes. Similar to that, but this is using a cutter to make a hole. Yeah.
But I think YY, you have done enough. You must have done enough children's eyes before.
Yeah.
You find that the capsule of a child, especially as an infant, does not behave the same as in an adult.
Definitely
in a child,
different.
you just poke a little hole there, or you make a cap. Whatever you do, it will just stretch into a nice circle. And even if you do a CCC, so-called anterior capsulotomy with an ocultome, it will look like a CCC, because it's elastic, it just stretches into a nice round opening.
Yeah.
So I think if you're just aspirating the lens, it's not an issue. But if you're going to do that in an adult and then you try and crack a hard nucleus, the CCC might not survive,
I was just going to say, I think because of the consistency of the capsule, really, I think in an adult capsule, we probably want to be more wary about using this technique, because you're actually making little scallop wounds all around. So it's not continuous, really. I think Becky already mentioned, if you're going to be dealing with a denser lens and manipulating more and cracking, you probably might run into trouble and perhaps get a rip. But I think, using it in the child, it's published, as Dr. Ho mentioned. One of my questions was actually, what do you have any tips? Because you can see that you made a posterior capsular rexis as well, or posterior capsulotomy. So do you have any tips in how you're going to inject an IOL into an open capsule, or the bag, capsule with an open bag? Anything that the audience can take away? Because obviously you don't want to put it through the back, through the opening. So do you have any tips?
Adequate viscoelastic, obviously, to open the bag, and the direction of the injector to inject slowly and make sure that the leading haptic is in the bag and not through the posterior capsulotomy. Yeah.
So you will inject straight into the bag and then dial it in, and not inject outside the bag and dial in the haptic separately?
No, I'll inject straight into the bag.
Okay. Any other different techniques from the panel of senior surgeons here?
I've actually seen people, or I've seen, in capsules that are fibrotic and calcified, that actually people advocated using vitrectomy cutter to deal with those really tough capsule. they think that it's very good, you know. Even better, some scissors sometimes you can't even cut, but the vitrectomy, I've seen people suggesting that they used it. I think it was a video of some Indian surgeons doing it. It seems to be pretty good, and he did a number of them, and quite successfully, you know, using a vitrectomy cutter for doing anterior capsulorhexis in fibrotic and calcified capsule.
Dennis, but if the fibrotic is too thick, do you think the vitrectomy cutter can cut through that thick fibrotic capsule?
I think you try everything: scissors, vitrectomy cutter. You just try everything. You have throw it on the capsule and see how it goes. But it can be very difficult, you know. I had one, nothing worked, and because the zonules were so weak as well, and finally, you know, you just sacrifice the back and do it at Yamane, you know. It can be very tough. Yeah.
Scissors usually will work. Like you have to have a long curve or angle Vanna scissors. It has to be a long one, you know. Then you can actually cut the fibrotic capsule. I just had one case the other day, which I use a bent 27G needle. I tried to actually did a can opener. Really difficult. I can't even puncture the capsule. So I have to use that needle to lift up the flap and then go in with a long angle Vanna scissors to cut the capsule. So sometimes, yes, it's very tough.
Yeah, but sometimes the zonules are weak, and you find that the capsule is rather not very taut, you know. It's like quite flimsy, and you cut it. It just sort of doesn't cut properly. You know, you cannot have there's no tension to the capsule to cut, and unless you have a really sharp scissors. I want to ask Dr. Ho, do you have to make sure that your posterior CCC is intact before you inject your lens into the back? I mean, if you have if it's not intact, there is a risk of radialization of the tears. If your posterior CCC is not intact, would that be? Do you think there's a risk?
Well, as we had mentioned just now, for children, the capsule is quite tough.
Yeah.
So it's unlikely to happen. And the CCC is posterior capsulotomy is pretty round. There's no weak points there.
Yeah.
Yeah, I think it's quite a unique situation of a pediatric eye there, which I think, you know, it's not just unique to that, but I think it's quite not simple, but the principle of it using the retractor to do everything, I think makes a lot of sense in a pediatric eye, because I'm sure Vicky will also agree that most of the time you do a little bit of anterior vitrectomy as well to prevent posterior PCO, and you do a posterior capsulorhexis. So I think that makes a lot of sense with 25 gauge system. Actually, I have another question. Earlier, back to the first run-out video using the flange proline. I think there was a comment about tilt and all that. I think what Dr. Wai Chung was talking about with the acros was the Canabrava technique, isn't it? I think that was the one that you highlighted in your video, step 1, step 2. I think that was the Canabrava technique using the acros. So I think the 2-point fixation lens, I've tried a couple of cases. I think in this case, I don't think we have any of those J-loop haptics where you actually can be foldable and have an eyelet as well. So what I've done also in a couple of cases, actually pass through the actual haptic itself, the haptic optic junction of a single piece lens. So I think there are other techniques that I think Canabrava is coming up with the IOL puncher as well to create an opening there so you can pass the suture through. The advantage is just a smaller incision rather than opening up to a 7. But I find that the flange proline, I think you mentioned you were pulling on both sides to get equal tension. One of the tricky things is to ensure that your knob is flush as possible with the IOL, and on the other side is also flush with the sclera, then you won't get any tilt. Because otherwise you can get tilt because this side can be sticking out a bit more, this side is a bit more flush, things like that. So that's the tricky part I think about this technique.
Yeah, I think with the aqueous lens actually is like a 4-point fixation because you do a loop, you see.
Yeah, correct.
You know, so it's actually I think a little bit easier to manage
yeah, but the looping is complicated, is it? The loop here, in, out there.
Yeah, it's a little bit complicated. Yeah, you have to be quite careful, otherwise you pull Yeah, it can be a bit tricky, but I think it actually is easier with the 2 point. I think you have to be really careful. Your marking and your tension has to be really right. Otherwise you can get tilt. But I think with Acros with 4-point fixation is a little bit easier to do. But I think after a while, I think it's quite tedious, and the loops can get a bit complicated. Yeah.
I think what's happening is we are using all kinds of off-label use of all these IOLs, except for the CZ. That's why I think good choice in this case, use a CZ because it's meant to be used this way. Whereas we are trying all kinds of funny things with kind of different IOLs not meant to be used for sclerofixation, really. Okay, I think we have probably another 5 minutes before we move on. Any other questions, perhaps from the actual winning surgeons to the others, the other surgeons about any of their videos?
Can I add something?
Mahathir, yes, of course.
Yeah. So basically, mine is not really a question, but more of a comment. I mean, it's always nice to have all these different devices that we have and the proper techniques, and we see all these latest techniques that a lot of surgeons do. But as Dr. Lim explained, sometimes you don't have all these things in your centers, and being able to think on your feet and being able to innovate and do the best that you can with what you have where you are is as important as learning all these different techniques. And this gives you, from his experience, it's a learning for those of us, especially in centers where you don't have all these things. We must always learn to think on our feet and use what we have on the spot. So I think it's very commendable, and I would like to congratulate all the winners. Very, very, very good videos and techniques. I think that's all for me.
I think that's one of the advantages of all these symposiums. They're trying to highlight, I think, the criteria, aside from just showing ways of doing things. It's not just about the way I do it and that's the best, but the educational value attached to it because the idea is people viewing this will have in mind some backup plan, or like you say, thinking on your feet about what you have. Oh, I saw that, that could be something I could be done, or I could actually plan for it if you can, and to deal with that scenario. So hopefully this is something that people can take away. I think I just summarize now for this category. So again, congratulations to our first runner-up and winners. I think excellent videos with good techniques. I think at the same time, not necessarily having to be absolutely novel, but how you approach the case, how you plan for the case. And there's some emphasis on the quality of videos and the narration and the appropriate use of music. I think those are important features that make a good surgical video. So I think Dr. Chin mentioned earlier, that's unfortunate. I think 1 or 2 videos where, they did not put in a narration or the music was a bit too loud, it sort of takes away sometimes the actual gist of the message. You get overpowered by other things. So I think congratulations again. I think our organizer will send those gifts or those prizes out to the respective winners. So I leave it to those of you who actually, the how you're going to share out, those of you that have a surgeon and also a co-producer, how you're going to share out the 2 or 4 terabytes. So I'll leave that to how you're going to share that out. So I'm going to move on now. We have the next part of the actual meeting. I hope we will have continuously good discussions as we move on, as what we just had with this category. So the next one I'll leave to Dr. Mahathir, who's going to start off the next section. So over to you, Dr. Mahathir. Oh, before I do
thank you.
Can I get everyone to actually just give a quick smile before you actually log off, because our organizer wants to take a nice photo so that we can actually have some good memories from that. So Jeannie, are you going to count down, or do we just show our pearly whites until you say okay? Are you ready? Okay.
Cheese.
Cheese. She's counting down the chat. Thank you.
Okay.
All right.
Thanks.
So again, sorry to interrupt. Over to Dr. Mahathir.
Okay. Shall I just take over, Sudha, or do you want to?
You can start now, Dr. Mahathir.
Okay, all right. Yeah, so I've been asked to introduce the videos that have been selected for the special mention. When, as the name implies, special mention videos are videos that the judges deem are worthy enough to be shown during the festival, although they did not garner enough points to be in the top three. As mentioned by Dr. Chin, I mean, if you are entering a video festival, because of the way it's marked, it's very important to have good video quality, good sound editing, and all that. But again, the lesson that we want to learn is also important. So, so that's why we come up with the special mention for videos that did not meet up to the required marks, but have good educational values or something to learn from them. Okay, so without wasting any more time, I would like to introduce the first video. It's entitled Tackling the Great White Cataract for Sharks. It's by Dr. Dennis Kong of the Eye Specialty Center, our founder of BOSS. So the video shows various challenges as well as techniques in overcoming challenges that comes with tackling, white cataracts. And then the good thing about the video is all the different techniques. So it's a good summary in one video of all the different techniques that you can use or challenges that you may face when facing this type of cataract. And at the end, there's also a brief analysis of the number of cases that he has done. So without taking any more time, let's roll to the video.
Tackling the great white cataracts can be fraught with hidden risks and challenges, like swimming in a sea and no idea what is underneath the surface. Opacified cortex may be hiding fibrotic capsules, dense nucleus, and even polar cataracts. Other possible intraoperative challenges are small pupils, weak zonules, high intracapsular pressure, and there is no cortex to protect the PC during nuclear disassembly. This video presentation will be highlighting the many challenges and the two key surgical techniques to manage these great white cataracts. Firstly, capsular management are dye, puncture, and immediate decompression. Secondly, nuclear disassembly techniques of segmental chops and scaffold techniques to protect the PC. Injection of capsular dye and OVD. Capsular puncture and immediate decompression to prevent uncontrolled tear of the capsule to the periphery. Decompression may be prolonged and repeated. Decompression is repeated as necessary until bulging tense capsule is flat or even slightly concave. Decompression often has to be repeated and in multiple quadrants. Sinski hook is used to stabilize eyeball and reduce eye movements. Venous scissors to cut fibrotic capsule, as forced tearing may result in an uncontrolled tear to the periphery. Capsular puncture and immediate and prolonged decompression in a Morganian cataract. milky cortex is repeatedly aspirated to improve visualization during capsulorhexis. Residual hypermobile dense cataract is disassembled by segmental chopping and scaffold techniques, which will be illustrated later. Capsular puncture and immediate decompression in phacolytic glaucoma and sustained aspiration of milky cortex. Milky cortex aspiration is repeated to improve visualization. Phacomorphic glaucoma managed by capsular puncture and immediate decompression and sustained aspiration of cortex. Iris hooks to retract myotic pupil and followed by capsulorhexis and nuclear disassembly. Nucleus disassembly is started with segmental chops, cracking the nucleus from the periphery to the center. The nucleus is rotated and multiple segmental chops done to eventually create loose nuclear segments. Emulsification of a loose nuclear segment anterior to other segments, which are acting as a scaffold to protect the PC since there is no cortex. Segmental chopping is less stressful on the CCC and capsule compared to conventional chopping when cracking is done across the whole nucleus. More segmental chops and scaffold techniques to protect the PC, which invariably is not protected by cortex in white mature cataracts. Liberal injection of OVD to protect the corneal endothelium and the PC. Injection of IOL posterior to the last nucleus segments to act as a scaffold. IOL acting as a scaffold to protect the PC when removing the last few nucleus segments. Retrospective analysis of 101 white cataracts, including 19 complicated ones and 82 uncomplicated ones. Completed intact CCC is achieved in 87.1%, break in CCC in 12.9%, and a PCR rate of 6.9%. Completed intact CCC of 87.1% is achieved using capsular management techniques of dye, immediate and repeated decompression, and scissors to cut fibrotic capsule. All corneal edema has cleared by 1 week except a severe one which took just over a week. In intact CCC, PCR rate was 3.4%. When there is a break in CCC, the PCR rate is much higher at 30.8%. PCR risk was much higher when CCC is not intact. Nuclear disassembly must proceed with great caution, and flat motility sign as described by Dr. Om Prakash should be closely observed. Key take-home points are: completed CCC is vitally important for safer nuclear disassembly and reduce PCR risk. Scaffold techniques to protect the PC since there is no cortex in white cataracts. Liberal usage of OVD to protect the corneal endothelium and PC. Thank you for watching.
All right. So I hope you all enjoyed that, all the challenging cases and as well as the analysis at the end. Let's move on to the next special mention. This is a video by Dr. Liu On Hyong from Hospital Queen Elizabeth in Kota Kinabalu, Sabah. His video is entitled Penetrating Keratoplasty with Yamani Scarificated Intraocular Lens Implantation, a combined technique. As a lot of people are starting to use Yamani technique, and it's become a regular technique in the armamentarium of surgeons now. We find more and more procedures where we can combine this technique with existing procedures to help in fixating the IOL. And this is one such example. So without wasting any more time, let's start the video.
Anterior segment trauma may result in corneal laceration and ruptured cataractous lens. An initial wound repair is often combined with lensectomy and limited anterior vitrectomy, leaving the eye aphakic and a scarred cornea. To address these issues, a penetrating keratoplasty can be performed with intraocular lens implantation, either sequential or in a single approach. Sequential approach offer better intraoperative surgical control. However, the sequence of surgery may impact subsequent steps. In PCAP first with IOL implantation later, the second operation may jeopardize the graft survival. In IOL implantation first with penetrating keratoplasty later, the corneal scar may hamper the view. Combined penetrating keratoplasty with open sky Yamani technique scleral fixation IOL can bypass these problems as shown in this video. After partial trephination of recipient cornea, cohesive viscoelastic is injected into anterior chamber and vitreous space, then followed by insertion of 30 gauge thin wall needles into the eye through sclera at 2 mm from the limbus at 180 degrees apart. Recipient cornea button was partially excised to leave a flap for just in case of suprachoroidal hemorrhage. And then the PVDF haptic of IOL were cannulated into 30 gauge needle and externalized. This followed by coagulation of distal end with high temperature cautery. After completion of open sky Yamani technique scleral fixation IOL, corneal button was excised completely and replaced with donor corneal button. cardinal suture applied, and then followed by removal of viscoelastic through Simcoe cannula. The remaining suture completed and buried, and sealer test was checked. Lastly, pharyngeal ring removed and then followed by subconjunctival steroid antibiotic injection. This was the picture taken at post-op day 7 and post-op 10 weeks. The surgical outcome was satisfied and patient was happy.
Dr. Mahadi, would you like to comment about the videos?
Yeah, thank you so much. I mean, it's such a amazing video, and since we have extra time, we've decided that we'll have a little discussion on the two videos in the special mention. So that's why we have everyone here. We apologize to Dr. Liu because we initially didn't plan to have a Q&A for the special mention, just to show them and garner some insights from them. But because we have some time, we decided to call all the panel back so that we can have a little discussion on the videos. So maybe Manwai, you can start it off.
Yeah, okay, all right. Congrats again to Dennis. I think the East Malaysians are showing us how it's done really. So many videos have come into to feature today, I think. So Dennis, you've shown a very good techniques of managing different types of white cataracts. Have you got any tips about, as you mentioned earlier, off camera just now, the different types of cataracts you have? I think pre-operatively, if we know, that will obviously give us a better idea of how to plan. So do you have any tips about pre-operative examination and picking up which type of white cataract you potentially could be dealing with on the table?
Yeah, I think clinically you look for, of course, fibrotic capsule. Then, of course, if you look at how tense the capsule are, whether it's convex. Of course, all the phacomorphic glaucoma, you know that usually it's very bulging, very tense. And then sometimes weak zonules, sometimes they're a bit difficult to tell. Even you get them to do saccadic movements, you may not pick it up. But I always of course you always stand those capsule and then you go in. And with the aim of decompressing, certain ones you may not be able to extract much liquid cortex. But I find that looking through my figures, about 80% of them I need to do significant decompression to really make the capsule at least flat or even slightly concave. And sometimes they are loculated as well, the liquid. So you may find that you do a bit of capsulorhexis and then you find the other areas look very bulging. And in that case, you better go and decompress first, because I'll try to complete the CCC and you get a radial sort of thing and you become a bit uncontrolled. So it's safer if you find that it's bulging to actually go and decompress first before you carry on with your CCC.
Yeah. I think the reason I asked is because I think the most feared complication in this kind of white cataracts is obviously Argentinian flag. I think that really, right at the beginning, you're already trying to salvage something when you have an Argentinian flag. So if you can pick up, and now you mentioned the water clefts, sometimes you can see them in the anterior capsule bulging forward, the intumescent type that you really have to decompress. you made a good point that you really want the anterior capsule to be convex, isn't it? In those cases, use a heavy OVD to push everything back to actually decompress. I found sometimes if you have access to anterior segment OCT or UBM or B scan, sometimes you can actually see the water clefts. And one of the things that I've actually been caught out before is a white cataract, a dense one, and it's a polar as well. So once you go in, open up, you start phaco, the whole thing just drops. So the other eye is one thing to look at. If you've got a fellow eye that's a polar, then maybe this eye might be a polar. Of the other eye, I've seen also where it's a pseudophakic, but there's a PC rent and somebody put a sulcus lens, then you might think, oh, this could be a polar that's gone dense. Then you again prepare yourself for that. Yeah. Any other comments from other people about a couple of videos?
Dennis, this is a question for you. When you put a needle in to decompress, is it bevel up or bevel down? Because it happened to me when I aspirate using bevel up, I caught the anterior capsule. Have it happened to you before?
No, I usually will actually bend my needle or did it ready to carry on the capsule rhexis. You notice that. I think some people just go in, decompress and come out, because I actually do my CCC using a needle. So I'll actually bend my needle, get ready to actually decompress and then carry on with my CCC. Usually if you try to dip it a little bit deeper, now don't be afraid, because this cataract are very deep, very, very thick, So you go in and just decompress. Don't decompress superficially, you'll be sucking the capsule. Yeah. You just go in and because I bend my needle, I have to tilt it slightly so that the sharp end is more sort of on the side, rather than in. You can go into the cortex. Yeah. No problem.
Yeah, I can share with you with this, because I have the same question about whether should bevel up or bevel down. Doesn't really matter actually. Both are equally the same. So as long as what important most is use good viscoelastic to really press the anterior capsule as flat as you can, and then when you go in with the needle, try to use nowadays I try to use a smaller needle, the 27 gauge needle. Whether it's bevel up, bevel down, doesn't matter. But be careful when you puncture. You must understand that there is always the needle. The needle itself may rest on the capsule. That itself may actually cause a slight tear of the anterior capsule. So when you withdraw, you got to watch carefully how far it has extended. In some cases, then only when you perform your CCD, you are in a careful, you're in a safe zone. I think it doesn't matter whether up and down. Doesn't make any difference. Try both also.
There's a question I think from the MSO website about decompression using IV mannitol. Do you do that routinely? Or if not, which types of cataract do you do that for? I think Dennis has a question about that.
I don't do it because I practice in the eye center and we don't have access to those mannitol, and I think certain patients it can be it may not it's quite, to me it's slightly invasive lah. I don't think routinely you need to decompress with IV mannitol. I know some people do, because I mean it can cause other volume effects and cardiac failure patient and things like this. So I don't routinely do. I just do a physical decompression when I during the CCC. I think the CCC is very important because it really sets you. If you have a nice CCC, you can be more confident about cracking your nucleus, especially if it's a hard one. If your CCC is not intact, I think it can be very difficult to go and disassemble, especially a very hard cataract nucleus, because the risk of the tear extending to the PC is quite high if your CCC is not intact. So I think it's a very critical stage that if you can get through that stage, your surgery tend to be much smooth, and PC rent is much lower, as you can see from my figures. So if I haven't got an intact CCC, my sort of threshold to convert will be much lower. I will, more easily convert if I run into problems.
Can I share this about IV monitor?
Yeah.
I think IV monitor is very useful in scenario whereby pre-existingly the patient coming with shallow anterior chamber and high IOP. Okay, so when IOP is high, you can actually use the IV monitor to actually shrink the vitreous. Hopefully, you know, it can decompress the, reduce the, deepen the anterior chamber, or even if not before the surgery, as long as the IOP is reduced, then it's much easier for you to use a viscoelastic to push the lens down in continuing to perform the surgery. In normal matured white cataract with normal IOP, I don't think a monitor is a necessity.
Yeah, I think the other thing you can do is, of course, I think the different scenario, I think the concerns that Dennis shared, of course, being in the practice where you may not have the support required if the patient runs into cardiac trouble. So the other thing you could do is do a limited pars plana anterior vitrectomy to soften the eye and drop the lens back and lower the IOP. There's a question here also, I think another couple of minutes before we move on to the next session is somebody asked about experience using phaco decompression. I think that was just now mentioned by Dr. Ho about something called punchorexis. I think it was described by Mohan Rajan from India. I think that's probably what he's talking about. He used a phaco probe in a white cataract intumescent actually, and just do a high volume quick suck with a phaco probe and create a nice round opening and suck out and decompress at the same time. I'm not sure any of you have tried it. I've not tried it. I think my heart is not as strong to do that. Has anyone tried?
Extra cost.
No, really use a phaco. You're going to use a phaco probe anyway. So he had a phaco bevel down.
Not vitrectomy probe.
No.
I think basically what you do is you know the cataract, you haven't done anything, you just dive in with your phaco probe and probably on high aspiration, and just suck away the cortex. It's just quite traumatic. I mean, it can be quite traumatic. I haven't really tried, you know. Maybe one day.
Oh, the video looks impressive when he presented it.
It makes sense lah. Only thing is, if you have done enough with needle puncturing and aspiration, it works well. Then when it works well, usually you will not want to try something that it appears to be, you know, challenging to us lah, you know. So
okay.
Jan Bon says he has tried it and it turned into an Argentinian flag.
Oh, did he?
Yeah, he did it and it turned into an Argentinian flag.
Okay.
Anyway, can I ask what good viscoelastic do you all use for this? What is your choice, Dennis? Or
myself, I just I use metacellulose. I use sodium hyaluronate. I think it doesn't
very heroic
too much.
Not Helon 5, Helon GV.
The only thing I say to others, you know, when they ask me about this is, do not use viscoelastic, metacellulose. All other viscoelastic probably you can try, but do not try out first with metacellulose.
There is one particular metacellulose that is pretty good. I can tell you can use it. It's called Cellugel. It's Alcon. Yeah, it's pretty good. It does stay in the eye. It doesn't come out like they are. I think the metacellulose, there are various grades and various qualities. No, they are not the same. I've tried others. One they're so liquid they don't stay. But if you try Cellugel, they do stay in the eye. You know, they're pretty good. You know, I don't know whether you actually try. If you haven't, get a sample from Alcon and try it. They're pretty good. I think that they do stay in the eye pretty well.
I think you have to move on.
Heavier OVDs lah, like Helon GV the most.
Yeah. In fact, those who never tried out this method before, I told them, you know, you can start with Helon GV, Helon 5. These are all Viscovis. These are those viscoelastic that they should try out first before they go into something that is more liquefied.
Yeah, basically high molecular weight. Okay, I think we have to move on. So I'll leave Dr. Sudha to actually carry on with the next section. Otherwise,
that was a good discussion. I learned quite a lot from this discussion. So in the interest of time, we'll have to move on to the next session now. The final session is the open session. Similar to the young ophthalmology session earlier, there will be also 3 top videos that will be played during the session. And this will be followed by a Q&A with the winners. Members of the audience can again post your questions on the comment session. I would like to now invite Dr. Koo to conduct the session. Dr. Koo?
Thank you, Dr. Sudha. Good afternoon to everyone. There are a total of 10 entries in this open category. And we as a judge, we have to pick the best 3 videos. Okay, so here are the results. The second runner-up goes to a case of challenging phaco implant by Dr. Chan Jan Bon from Isaac. Okay, iris fixated IOL was quite popular a long time ago, not long time ago, sorry. And now we are starting to see cases of its complication. Okay, let's see how Dr. Chan deals with one of the commonest complications in its phakic IOL. Video, please.
Hi, this is Dr. Chan Jenbot from Isaac KL. Welcome to BOSS 2021. This is a case of a challenging phakic implant. This is exactly what happened to my patient. He was playing with his son and he accidentally punched his eyes. My patient is a 36-year-old man with a history of right eye sudden blurring of vision of one day after being punched by his son. He had bilateral eye phakic IOL implant done at the age of 21, 15 years ago. He's a very high myope with -12 on both eyes. On examination of the right eye, there's a claw lens that has dislodged inferiorly. The lens is touching the endothelium, causing corneal edema. His vision was 660, but his best corrected vision was 6.7.5. He was also noted to have bilateral immature cataract. This is the specular microscopy of the patient. The cell count on both eyes is actually pretty high, despite having the varices in the eye for 15 years. His lens is a varices lens, which is similar to an artisan lens. Back then, this lens was intended for phakic IOL implant. Of recent years, this IOL was found to be problematic, causing cataracts and reduced endothelial cell count. Hence, it is recommended to remove this IOL if necessary. There are 3 options: to remove the varices lens and insert an ICL, or to remove the varices and do a phacoemulsification, put in a multifocal implant since the patient already has mild cataract, or to realign the varices lens. Both ICL and multifocal implant will be difficult as the lens is not readily available. After a long discussion with the patient, we have both agreed to reattach the IOL. The first step is to give local anesthesia, which is subtenon. Intracameral lignocaine will not be advisable as this will cause the pupil to dilate. Local anesthesia would be required as it will cause a lot of pain as we are touching the iris. 2 wounds will be required, one in the temporal and one in the superior. I then inject some viscoelastic to form the anterior chamber. It is also crucial not to over-inject the eye as this may push the IOL inferiorly, touching the lens. I now try to recenter the lens with a forceps, pulling it to the center, gently without touching any other parts of the eye. Once it is centered, we have to reattach the claw back to the iris. The most common way to do this is to use a cannula, pushing the iris back into the claw. Of course, in this case will be impossible, hence I use a micrograsper instead. By using a forceps on the left hand, grasp the varices lens to make it stabilize, and with your right hand, use the micrograsper and pull the iris through the claw area of the varices lens. A few attempts was needed as it was not easy to visualize that area. There was pre-existing corneal edema from the lens touch. Care must be taken not to injure any part of the eye, especially the phakic lens, as this may induce cataract in the patient and may cause uveitis as well. After I've successfully reattached the IOL, I wash out the remaining viscoelastic in the eye by flushing out with some balanced salt solution. As the viscoelastic was too viscous, I was unable to wash out all the viscoelastic. I proceeded to use a Simcoe to actually remove the remaining viscoelastic in the eye. As you may have noticed, the pupil is dilating. That is because I did not realize that the balanced salt solution was preloaded with adrenaline. Again, in this situation, we should not be overfilling the eye with BSS and also oversucking the Simcoe, causing the anterior chamber to collapse. Once all the viscoelastic has been removed, I injected the patient with some myostat to reconstrict the pupil again. and I end it with some intracameral antibiotics. This is how the eye looks like on post-op day 1. His vision was 6/12/6/9 with a residual astigmatism of 150, which is similar to his vision before op. This is how it looks like 1 week post-op. The corneal edema has also resolved. Thank you very much. Hope everyone learned something today.
Congratulations, Dr. Chan. Next, may I present you the first runner-up, Pulse and Modified Flange Sclera IOL Fixation by Dr. Yong Jen Yi from Sarawak General Hospital. There are many ways to fixate a sclera IOL. Dr. Yong is going to show us another way of doing it. Can you have the video, please?
Pulse and modified flange scleral IOL fixation is a topic of mine today. I am Dr. Yong Geng Yi, ophthalmologist from the Sarawak General Hospital. I have no financial interest to disclose. These are the materials used, particularly a low heat diatomy, Prolene 60 and 27 gauge needle. I'm presenting the technique step by step how to achieve a stable IOL fixation and avoid complications. The important step before you start the surgery is to make a precise marking. I use toric marker to cast the perfect 2 lines 180 degrees apart. Then, I mark 2 mm horizontally away from the limbus and another 2 mm vertically. I also perform the same step at the opposite side. This gives a good idea as to where I am going to place the 27 gauge needles. A 7 mm width scleral tunnel was performed for CZ70BD IOL. An alternative would be a corneal wound. However, scleral tunnel was chosen in this case to reduce the risk of astigmatism. CZ70BD was the IOL of choice because of its good track record of IOL centration. Preload 60 Prolene in a 27 gauge needle before transconjunctival sclerostomy. I was then displace the conjunctiva slightly before sclerostomy. The tunneling is 2 mm vertically and horizontally. Avoid poking in the needle directly without tunneling. Once one needle is in, and that can be used as a traction to hold the eye, and repeat the same step on the other side. Then, externalize the Prolene with microforceps through main wound. We also recommend to insert the Prolene into the eyelid from the top. Then, the flange created with low heat diatomy will be located at the inferior part of the eyelid. The issue of long-term viability of Prolene suture presents a particularly important concern for patients. Prolene 60 is suggested as it is more durable than the final Prolene 90 or 10O that was previously used in scleral sutured IOL. Case studies have indicated that over time, the 10O Prolene suture can degrade, resulting in spontaneous subluxation of the IOL. After preparing the first and the second flanges, IOL is implanted at the sulcus. The IOL was positioned centrally with externalized Prolene. Main wound was closed with nylon 10O. The third and the fourth flanges were created and buried in the sclera with gentle tapping by forceps. The conjunctiva was adjusted so that it covered the flanges and the sclerotomy side. Conjunctiva was closed with absorbable suture. Lastly, subconjunctiva DEXA cefuroxime was given. Immediate visual recovery with great patient satisfaction can be observed during day 1 and week 1 post-op. The IOL is stable, centration is good, and he attained a final vision of Cataract 6.6. There are 10 pearls to be shared today. Pearl number 1, precise marking 2 mm for a good IOL centration. Pearl number 2, adequate width of sclera or corneal wound for insertion of IOL. 3, preload 6O Prolene in a 27 gauge needle and externalize the Prolene with macroforceps. This modified technique simplify and reduce intraocular manipulation. 4. Displace conjunctiva before sclerostomy with 27 gauge needle. Conjunctiva acts as a tamponade over the sclerostomy site. 5. Prolene enter the IOL eyelids from the superior. The eyelids on the haptics are higher than the curve optic. With the Prolene enter the eyelid from superior, the flanges created are within the safe zone to minimize the contact and friction. This modified technique helps to prevent UGH. 6. Keeping the eye infused with an AC maintainer or a pars plana infusion port. 7. Tighten 2 Prolene opposite to each other simultaneously. Lens come in a nice position. 8. Flanges are created using a low heat diatomy. 9. Externalized Prolene are cut 2 mm from sclera before creating the third and the fourth flanges. Ensure they are equally taut to prevent IOL decentration. 10. Bury the flanges in the sclera by tapping it lightly and cover with conjunctiva to seal off the tunnel and prevent conjunctiva erosion. This technique is applicable for an explanted one-piece IOL as well. Thanks for watching and I hope you enjoyed the video.
Congrats, Dr. Yong. Very nice video. Looks like it's a very popular method now. All right, and now I'm going to present you the winner of BOSS 2021 from Tone, Dr. Chong Yan Yao, with his video title, Doctor, I can see my own lens in my eye. Really? Well, it is real, and this is what Dr. Chong meant by it. Video, please.
This is a 52-year-old lady presented in October 2020 with left fluctuation of vision for about a week prior. She denied any trauma to the left eye. Examination then found left phacodonosis, shallow anterior chamber, but the IOP was still normal. A PI was performed and she was advised to use pilocarpine eye drops. She had a number of follow-ups since then, and each time the IOP was normal and the anterior chamber was still shallow. Then on the 3rd of August 2021, she came without appointment and claimed to be able to see her own lens in the left eye the same morning. Examination showed a dislocated crystalline lens in the anterior chamber with endothelial touch. As the lens was touching on the cornea, an emergency surgery was scheduled the following day to prevent further damage to the cornea. The plan was to perform phaco as the lens appeared to be soft and follow with anterior vitrectomy, then scalp fixation of a foldable IOL. This plan can be performed with small incision with predictable outcome. Entry of blades into anterior chamber was performed carefully as not to damage the lens prematurely. Viscoelastic injected to separate the lens from the corneal endothelium. More viscoelastic was injected to create bigger space for the entry of keratom. Because the lens appeared to be soft, the plan was to penetrate the lens with a phaco tip and to aspirate and also to phaco the lens material within the bag as much as possible so that the vitreous would not be disturbed. When the vitreous was noted to be disturbed and getting to the phaco port, the remaining lens matter was then removed with vitrectomy cutter. The cutting rate is set at about 1000 cut per minute as to be able to remove the lens material more efficiently. Once it's purely cutting the vitreous, then the cutting rate can increase to maximum of 4000 cut per minute with these Centurion machines. A PI was then performed with a cutting rate of 100 cut per minute. With viscoelastic in the anterior chamber, implantation of IOL does not require turning on the infusion. This makes the implantation process a better control maneuver. This is a demonstration of a modified Yamane technique of sclera fixation of IOL. Both the haptics were implanted into the anterior chamber and rotated into this position to facilitate subsequent manipulation. Accurate marking is very crucial to ensure the success of this surgery. In order to ensure the precision of entry point, the needle should enter the sclera at the point of marking. At once the needle bevel intrasclerally horizontally until the entire needle bevel is buried, then turn the needle about 45 degrees and at once further into the eye. Grabs the haptic with a 23G micro forceps, then feed the haptic into the needle bevel. Be very careful in catching the haptic. Sometimes you may accidentally catch on the iris as well. Withdraw the needle in a direction along an imagination line on how the haptic will emerge from the sclerotomy. This is to avoid distortion at the haptic-optic junction. Do not touch the haptic with the thermocautery. Use the radiation heat to create a small terminal bulb. The same maneuver to retrieve the second haptics, only just bear in mind that the second haptic is more difficult to treat into the needle. Both the haptics were pushed back into the eye slowly and observe for centration and tilt. And in most cases, the surgery can be performed sutureless.
Holding slide. We're on holding slide now. Live is
That was a really interesting video. So now we are again at the Q&A session where the winners will be asked questions by the judges, and members from the audience, you still have time to post your questions if you have any. Dr. Lee, would you like to start the session?
Yeah, sure. Congratulations again to the winners. I think Dr. Yong, Dr. Chan, and Dr. Chung. So interestingly, I think we will talk about it. I think you see that a lot of the winning videos are talking about management of complicated cases, of course, because that's all what we want to learn, how to manage complicated cases. But not just that, I think at the same time, they have done it in a very instructive way. And I think there are lots of things that we can take away. So can we start off perhaps, Dr. Koo, have you got any specific questions, having, judged this category, or rather presided over this category, any questions specifically to the surgeons?
Yes, Dr. Chan. Yeah, just a question. Let's say you got a dislocated iris fixated IOL, and you want to fixate back to the same spot. But that spot, you have a large iris atrophy. What do you do?
I think I'll take it out then, because there's no point putting it in. In this case, because it's sort of an emergency, there's already corneal decompensation, and then if I take out, I have to do something about it in the end, to do a phaco or something. And the patient is not keen to wear a contact lens because the other eye, it's like 0, right? So it would be a very bad anisometropia for him. So that was the decision made by the patient, and me agreed, you see.
The thing with actually, what's the difference between a Verisize and Artisan? Is it the bolting, or is it just different branding?
I think it's the branding.
The branding, right?
I haven't really seen this lens before. It's my first time seeing it.
Okay.
Yeah.
If you have your enclavation points, usually it's horizontal, isn't it? Can you actually move it a bit oblique or even vertical? Let's say,
not easy.
Not easy, yeah?
Not easy. You have to do superior. With this rigid lens, has to be 5.5 millimeter in size, so it's a sclera tunnel incision. You have to anchor it. Of course, you can tilt a little bit, but it's recommended at 0 and 180. So there's no toric version when it comes to the rigid lens. They have a silicone version, which is a foldable. You can go through a cornea. I'm not sure whether it's still available. That version can come with a toric version.
I see. Okay.
And the difference is, the question is, the Verisize is marketed in US, Artisan is elsewhere. Okay, and the phakic implant, the design is slightly different from the aphakic Artisan lens. It's totally different ball game when you implant a phakic Artisan lens and aphakic Artisan lens is totally different.
Oh, okay.
When you do a aphakic Artisan lens, there is no lens behind, so it's very easy. The AC is very deep, and you have no worry about endothelial touch or damage. Not so concerned about lens behind it. When you do a phakic Artisan lens, you have to take care of the cornea. You have to watch out the crystalline lens. So and the AC is not as deep as the aphakic eye. So it's a very different, it's a very tricky surgery.
Okay. Good stuff.
So now the trend is more towards ICL, isn't it, rather than this anterior chamber phakic implant?
Because the ICL is very easy to implant compared to Artisan lens. Artisan lens is very tricky to implant. Not everybody can do it.
Well, I mean, you say that, but a lot of people use that retropupillary as well, isn't it? I think, it's a lot of some of the colleagues.
But that one is aphakic. There's an aphakic version. You can do retropupillary, not the phakic.
Sure. What I mean is, you mean the difficulty is working within the eye with a small space, or getting the enclavation that's difficult?
Oh, the difficulty is because when you're doing a fake kick, I'm talking about difficulty
No
is
space,
fake kick, IOL, not the A fake kick. That's why it's difficult. That's why ICL become very popular because it's much easier to do.
So what is the difference actually between I mean implanting of anterior artisan A fake kick versus fake kick?
Your question again?
What do you mean by the difference in the inserting?
Oh, the difference is, as I
yeah.
mentioned earlier, the difference is one is with a lens, crystalline lens there. One has no lens there. So
Just a
the anterior chamber
technical-
depth is different. You do not have to worry about touching the crystalline lens when doing a fake kick. So you can, you know,
But comparing the
totally different.
retropupillary and anterior artisan lens in a fake kick eye, actually I feel that retropupillary much easier compared to anterior a fake kick artisan. Technically it's a bit easier retropupillary.
Okay. Another question actually I wanted to ask to Dr. Yong. Congratulations on a very nice 10 pearls. I like these kind of videos where you have 1, 2, 3, 4, you know, that kind of things. Very systematic to tell you what are the things that you need to do. I think whether it's coincidental or not, I think, you know, the first run-up spot, whether in this category or in the YO category also was showing the same thing. So you are doing very similar surgeries with flange proline with a CZ, but you use a scleral tunnel. I think one difference, you find that, did you start off using this technique using the same Yamane tunnels, or did you go, because you look at the way they actually described it, they just went straight through. Did you intentionally create the Yamane tunnels to improve your fixation? You're muted. You gotta unmute yourself.
Thank you for the question. Actually, I just create a scleral tunnel. Like I want to make a 7 mm scleral tunnel, but I didn't.
What I mean
actually...
is for your needles when you for the proline sutures, because you created your 2 mm kind of tunnels as well.
Oh yeah, okay. So for the 2 mm side, each side at 9 o'clock and also at the 3 o'clock, I make it in a way that I turn 90 degrees away. So it's something like a Yamane technique, but it's actually similar, just to have a better centration for the IOL. Yes.
You think it gives you better centration?
Yes.
You've tried it with a straight in as well, presumably.
Yeah, straight in, but turn 90 degrees away.
No, what I mean is you've tried it with the conventional flange proline technique is they just go straight in. They don't do the tunnel like a Yamane. So have you compared the two? I mean, I've not done it with the tunnel, I've done it with the
yeah, I got no experience by poking in the needle straight in.
Okay. Any other questions?
I have a question for Dr. Chung actually.
Okay.
About like the case earlier, you chose to, where there's a pre-planning required for a lens which is not going to sit in the bag. So you chose a scleral fixated lens. So in which cases would you choose an iris claw instead? Like if any of the others in the panel as well, if you think that you're going to choose a lens that's not going to be in the bag, would you choose a iris claw lens or scleral fixated lens? And what are the pros and cons?
It all depends on what you're comfortable with. I think currently from the literature, both the lens do good results with minimal endothelial loss in those with long follow-up. So it all depends on what you are comfortable with. The difference to me, with artisan lens, you need to use a large wound. So it's an advantage to me, as someone who usually when we do phaco is 2.4, mine is 2.4 millimeter incision, to even enlarge the wound to 5 millimeter to implant the aphakic, this artisan lens, under the microscope, it looks huge to me. So I have to do anything go beyond 5. I would prefer to do scleral tunnel rather than cornea incision. But a foldable lens that can go through 2.4 or 2.5, like the 3 pieces lens that I'm using right now. So I don't have to enlarge the wound. That's number one, the advantage. Number two, it can be sutureless. and I can control the astigmatism if I needed to. So these are some of the advantages compared to the artisan lens. I'm sure those who are experienced in implanting artisan lens, they also find it very comfortable in doing that. There's no problem, you know, if they feel comfortable in doing that. But because of the advantages, the extra advantages from scleral fixation, I still, you know, tends to promote this technique like in that manner. You know, advise you know, anybody who wanted to venture into putting in aphakic lenses to try to go into scleral fixation rather than artisan lens. But bear in mind, there's definitely a learning curve, a huge learning curve. Easy to see my video or anybody video in doing this scleral fixation. But once you start doing it, you will suddenly find that there's a lot of issues, you know, centration, tilting, putting in the needle, actually treating the haptic into the needle. It looks, once you have, of course, you know, you look at my video, it may seems like quite straightforward, but in a lot of new surgeons, consultants, they actually find it very difficult to actually place the haptic into the needle hub. So easy to see, but once you start doing, it's quite difficult, quite tricky. Perhaps the artisan lens is easier to master compared to scleral fixation. That could be the disadvantages.
I wonder, in your case, that's true.
Yeah.
The position of the lens is in anterior chamber. Will it sort of interfere with the biometry? I mean, you know, the calculation.
It shouldn't interfere because it's the biometry, the optical biometry is able to pick up the axial length, so shouldn't interfere. It's just like those patients who had an artisan lens or who had an ICL and they need a cataract surgery, they can just go for a normal measurement without any special calculation.
I think back to Sudha's question, I think it's probably the panel here may have a bias towards scleral fixation. You can have another whole discussion on people who prefer iris fixation as well. I mean, I prefer scleral fixation, I think, for the reasons that Dr. Chung mentioned. At the same time, also, I find it's probably in a more physiological position to have a lens there. And to me, the iris tissue, a bit too dynamic to actually have things clipped onto it, might be moving around. Anyway, you know, there's another argument. I think it's not been shown in papers that one is better than the other. I think it's still what you're comfortable with. But I echo those points that Dr. Chung made about, you know, Yamane. It looks great, to be honest. And then once you start on the journey, it can be a bit frustrating. I think he himself will attest to the fact that until he found the beautiful PVDF haptics, he gave up for a while because he didn't want the PMMA haptics because it caused so much problems. But we persist with it. I think it's a beautiful technique. I'm sure, you know, everybody here, like Dennis, will say the same, and Ricky and Mahathir as well.
I think the problem with artisan lens and so on, especially if you are practicing in the Borneo states, I tell you, to get lens courier over easily a week, you know, and time factor and more expensive. So it'll be much easier if you can use whatever lens you have in your stock, you know, 3-piece lenses to do scleral fixation. I think there is a learning curve, obviously, to do it, but I think it's not insurmountable. Like you can do it. But I usually like the second haptic. Usually I would rather take it from outside and bring it in and cannulate. I find it a little bit easier. Yeah.
I
want to ask Dr. Yong, what lens did you use? Sorry, I didn't sort of catch it.
Okay, I use a CZ70 BD because it is a hard lens, PMMA, quite rigid. So I find it is can cause less tilting compared with other lenses, such as a one-piece acrylic lens, which is soft, and the structure may alter by pulling the prolin when you want to tighten it. And the one-piece LL without cutting off the haptics may cause shuffling to the iris and later on leads to the UGH. Yeah. So that's for one piece. And for three-piece LL, actually we can use it similar method. Use proline and diatomize, and we crush, make a hole. Yeah, so that's for a three-piece. Actually, this Canberra technique can be used for different kind of lenses.
Yeah.
I think you mean you actually make the 6O proline into a big hub, crush it, and then you thread the three-piece PMMA hectic through there, and then you flange the other side as well.
Yes.
Yeah, it's the same principle as Yamane. I think he started it all off with all this.
Wanted to ask Dr. Chung a question actually on this case. Dr. Chung, you were doing a phaco on the lens and then there wasn't anything behind. Would you have maybe done halfway and then insert a IOL behind the lens just to scaffold it or something? Just thinking whether that will actually work better than, because it looks like it's quite open.
Yeah, that's why this is a whole lens. There's no more capsule behind. The entire lens is in the anterior chamber. So what I did was actually I initially there's also a worry about this lens. The potentially can drop. But I believe this patient, the anterior hyaloid phase is still present. So that's why there's no vitreous prolapse. So that's one good thing. The other thing is I find that the lens appears to be very soft. So what I did was actually straight away I used the phaco tip to puncture the lens. Okay, so almost the first half of the lens actually is aspirated with minimal phaco power within the whole lens capsule. Right. Then only at the second half of the lens, then of course the capsule they collapse and eaten up by the retractor. So I have to slowly eat up the whole thing with the phaco probe. The only thing that time I worried is more of like vitreous coming forward. That may drag the vitreous, and also of course the lens material may drop later into the vitreous cavity. Well, anyway, so actually my standby things will be to inject viscoelastic behind the lens to complete my surgery. But it seems for this particular case, everything seems to happen still within the anterior chamber. So I did not need to inject some more viscoelastic behind the lens. So I able to complete the whole thing.
That's why I was thinking whether should put in maybe a scaffold lens there so that it won't drop behind or nothing will come.
What sort of scaffold lens? Because there's no support behind.
Your lens, your three-piece lens that you were planning to do your what do you call this?
That means I have to put the lens in the anterior chamber
first.
Yeah, then I'm going to push this subluxated lens more anteriorly. So that may actually, the lens is by itself is already touching the cornea on presentation. So I actually have to use viscoelastic to push the lens down a little to protect to separate the lens from the cornea. So there's not much room, not much space for me to actually put a lens behind this crystalline lens. So no, I don't think I will put a lens behind, because this is going to push the cataract lens, the subluxated, dislocated lens even more anterior and cause damage to the cornea.
I think my opinion will be, I'll be more inclined to do what Jan Bond has suggested by putting a three-piece IOL behind the dislocated lens, and because actually the iris diaphragm is not a fixed structure, it's flexible. So if you increase viscoelastic pump into the AC, you will deepen it down, and of course like you did, I think
there will be a problem if, let's say, you put it behind, and then while doing the work in the anterior chamber, your this fluidic may accidentally push your three-piece lens into the vitreous cavity.
You could leave the trailing haptic out of the wound so that there's some control there. That's
Yeah,
what I
yeah.
usually do if I do quite a lot of IOL scaffold in mature cataract, or especially if the AC is not very stable and I'm left with a few segments left, I will actually put in a IOL as a scaffold to protect the PC. I find it works quite well. Yeah, I think like you show, I think this sort of lens, if you are afraid of drop into the vitreous, you have to phaco it one piece. You mustn't chop it. You know, you should just eat it away slowly, and just phaco it one piece. Yeah, I think that's the important point. Otherwise, the risk of dropping is higher.
I think the other thing you can use is a sheets glide. People have talked about sheets glide as well, besides the IOL scaffold as one.
Yeah.
And in a softer lens, perhaps you could consider your chopper or something blunt you can actually skewer the lens because it's soft. You can skewer and hold it in place and slowly chip away with your phaco probe. And then of course, ultimately, I'm sure Wawa had a VR surgeon stand by also, right? No, I'm just joking. Anyway, it was well done. It has some good discussion. Any last burning questions? Got a couple of minutes. Vicky or Mahathir or anyone?
I think, I think whoever has watched YY's video and thinks that Yamane is kind of straightforward, there's another video submission. It's called 15 Mayday moments in my Yamane implantation. Yeah, we should watch that as well. You know, that one shows a real life situation that can be encountered when someone is trying to, is on the learning curve.
Yeah. I think that was actually, I think the judges were a bit split on that video, I'll be honest with you. I think some of us thought that it was good to show the real problems you encounter. And some of us thought that, you know, as a teaching tool, perhaps we won't want to put that as something where people can just see and just try and float through as we are actually going step by step. I think one of the points made is, you know, all these beautiful Yamane videos are edited, of course, and they show you the nice ways of doing it. I mean, those are principles. But at the same time, you know, with any sort of video surgical instruction, we're trying to teach principles, not so much exactly just follow wholesale what the actual surgeon is doing. Okay, any final words?
Yeah, I think like surgery, you know, I think surgery is this one. Cataract surgery can be nice, simple, so straightforward, and yet it can be very, very difficult. I think like any surgical procedure, Yamane, if you do it well, sometimes you know it goes really smoothly. But there are other times when you can struggle. So it is important to, I think, develop slowly more skills and look at different videos and how people handle different challenges, you know, to be a little bit more versatile. I think, you know, I think surgery is a learning curve, lah. Yeah.
Okay.
Before we close the Q&A session, everyone please pose for a picture. Jeannie will be taking one.
Cheese. Okay.
That's done. So I would like to invite Dr. Lee and Dr. Dennis to give the closing remarks now. Thank you, judges. Thank you for to the panel and the winners for taking part in the Q&A session.
Well, I think we've had 2 hours and a bit just flown by. I think we've had some interesting discussions and very useful, I hope. I hope the audience has actually gathered some pointers as to how to move forward to deal with some certain complicated situation. And it seems that it was a bit of a scleral fixation masterclass today as well. So I think it remains me to thank, of course, I think there's a lot of organization headache involved with this. So of course, BOSS side as well as MSCRS side, the committee for contributing to the planning of this event. Jeannie and her team for the technical side and organization as well, and MSO for allowing us to host this on the website, as well as I think all this was made possible also from an educational grant from Alcon. I hope to move forward with more collaborations with BOSS, and as you see, you know, West Malaysia is lagging somewhat, and we got so many winners coming from East Malaysia. I think we have to do better. So hopefully everybody, we should need to create more videos. And Sudha, I know as the chair of the young people, please inspire them to do more. I think it remains me to hand over to Dennis. I think he will actually close off with some remarks about today's event and the future. So Dennis, over to you.
Thank you, Bang Wai. Congratulations again to all the winners, YY, Jen Bond, Dr. Yong, and also the YO winners, Dr. Ho and Dr. Chua, and Dr. Tiong, and who is the other one? Yeah, I think I'm very impressed by Strathclyde General Hospital. They've really come and swept the the video festival. They've won the three of the prizes. So very impressed indeed. A big thank you to Alcon, of course, for providing the educational grant, and MS4 for supporting the event. Thank you to Jeannie and her team for some nice introductory videos and organizing and making sure that the event run seamlessly. Of course, thank you to Man Wai, my co-chair, my committee members, and also the panel of judges for doing a great work in picking up the winners. I'm sure it was not easy. They've spent a lot of time maybe reviewing the videos again and again to pick the winners. I urge all of you actually to because these videos will be on MSO website as well as Borneo Ophthalmology YouTube, all the videos that have been submitted. I'm sure if you go through and see all these videos, you know, not only just the one that have been presented, but others that have been submitted, I'm sure you pick up some great tips and great techniques that you can incorporate in your daily practice. I mean, I'm actually quite, because I'm not one of the judges, so I haven't seen the other videos. I mean, there are some videos I really like to see, like Dr. Peter Kong about his, you know, how he can work without moving too many things, you know, in his OT setup, how to work efficiently. I think there are a lot of tips, and the May Day, of course, as well, the Yamane 15 May days you can encounter in a Yamane technique, and hopefully that video also provides solutions how to overcome those May Day, you know. So I would urge everybody to see those videos and actually, you know, and learn the tips and incorporate that into your daily practice. I think BOSS will be committed to organizing more video festivals in future, and I'll urge everyone to keep recording, editing, and presenting their videos, and hopefully next year we'll get a bigger number of submissions, and also in future I look forward to collaborating with MSCRS, especially if we are going to hold bigger events like hybrid events, for instance. I think that'd be great if we can do a hybrid once in a few years, you know, have a chance to meet in person as well as, you know, do it virtually. I think that would be fantastic. Okay, I think that's all I have to say. Thank you very much, and stay safe, everybody. Yeah, thank you.
Okay, thank you all for attending this year's BOSS MSCRS Festival. Hope all of you enjoyed the sessions as much as I did today. Congratulations to the winners, and thank you to all those who submitted videos to this year's BOSS MSCRS Cataract Festival. All 18 videos submitted will be available to watch on the Borneo Ophthalmology YouTube channel, as Dr. Dennis mentioned earlier. With that, I thank you again and have a great evening all. Thanks.
Thank you. Bye-bye. Stay safe, everybody. Here we meet again.